Very good morning to all students. So today's lecture is on dental caries and we'll be covering this in two parts, part 1 and part 2. So in today's lecture we'll be discussing the basics of dental caries like the definitions, terminologies and just general information regarding the etiology and the clinical characteristics of the caries lesions. Now, we're moving on to the definition of dental caries. Here we've discussed two different definitions of dental caries from two different editions of Sturdivant. Just to indicate how over time our understanding of caries has deepened and changed and evolved. So according to the fourth edition, dental caries is an infectious microbial disease of the teeth that results in localized dissolution and destruction of the calcified tissue. According to Sturdivant's sixth edition, dental caries is a multifactorial, transmissible, infectious oral disease caused primarily by the complex interaction of cariogenic oral flora with the fermentable dietary carbohydrates on the tooth surface over time. Now, with the explosion in cariology studies, we had a deeper and better understanding of caries over time. As you know, dental caries is as old as mankind and has had the longest association with the dental profession. So, of course, the definition of caries has undergone a lot of changes. The transmissible word here in the definition mainly came from the Keys Fitzgerald revolution, in which they carried out even before them Orlando et al. Carried out experiments which were reinforced by then Fitzgerald and Key, which resulted in inclusion of this word. In order to treat dental caries, it is imperative for us to look beyond just those black and white spots, that manifest on the tooth surfaces, because dental caries onset and activity is a very complex process with several modifying risk factors and several protective risk factors that influence the dental caries process, which eventually we'll be discussing in detail further. So at the level of the tooth, the caries occurs mainly by a dynamic process of attack and repair that is known as the demineralization and remineralization balance. And in this demineralization-remineralization balance, there are two main factors, pathologic and protective factors. So pathologic factors are those that favor demineralization and protective factors are those that favor remineralization. So to understand this particular balance or cycle, we need to understand that individuals in whom the balance tilts predominantly towards protective factors, that is where the balance tilts towards factors that are favoring remineralization, they have lesser chances of developing caries. Whereas if it's the other way around, those individuals have higher chances of developing caries. Now, coming on to the caries balance, as we discussed earlier, to understand the demineralization remineralization cycle, we need to understand pathological factors and protective factors. Pathological factors are the ones that favor demineralization. So they are acid producing bacteria. So acid producing bacteria is usually they produce organic acids as byproducts which result in demineralization of the enamel structure. Subnormal salivary flow or function. Saliva in itself is an anti-caries agent. It has many activities, many properties like antibacterial activity, buffer capacity, remineralization. All of this prevents caries or helps in saliva acting as an anti-caries agent. So any detrimental effect on the quality of saliva or the function of saliva will in turn have a detrimental effect on the tooth surface. Frequent eating or drinking of fermentable carbohydrates, like we discussed earlier in the definition of caries. Caries is caused by the complex interaction of cariogenic oral microflora and the fermentable carbohydrates. So therefore, the more we consume fermentable carbohydrates, the higher the chances are of having dental caries. Poor oral hygiene is a pathological factor because poor oral hygiene usually results in more accumulation of plaque biofilms, which in turn results in demineralization. Now coming on to the second factors, that is the protective factor which favor remineralization. So first is the salivary flow and components. Saliva has various components. There are salivary enzymes like lysozyme, lipases, which have various antibacterial activities or antimicrobial activities, even lactoferrin, agglutinins. These are all proteins that produce antibacterial effects. Salivary flow, because adults usually produce 1 to 1.5 liters of saliva. Salivary flow, basically the quantity of saliva has a flushing effect that is effective in flushing out the microorganisms which have adhered to the oral structure. So that is how saliva helps in acting as an anti-caries agent. Second is remineralization, that is fluoride, calcium, and phosphate. So additional fluoride or calcium or phosphate intake will always help in remineralization. Antibacterials like fluoride, chlorhexidine, xylitol, all of these prevent or disintegrate the plaque microbial biofilms, and good oral hygiene, of course, will always favor remineralization. This is the famous Keys-Jordan diagram, both traditional and modified. On your left, you see the traditional Keys-Jordan diagram. On your right is the modified Keys-Jordan diagram. Now, all of us are familiar with the Venn diagram, and this is a Venn diagram with 3 to 4 intersecting circles. So, out of these two circles, depict the diet and the dental plaque or the microbial factor. There is a third circle which depicts the host. So the plaque and the dietary factors, or the microbes and the dietary factors, are interdependent on each other for causing damage, that is for causing caries. And the host factor here is the platform for this interaction, that is the host is where all these factors interact. And the host is also the victim in this interaction, that is the host is the one that suffers the detrimental effects of these interacting factors, and it is the host that um, develops caries. The intersected section of all these circles depicts caries. There is a fourth circle which is the time or the frequency factor. So it depicts the duration of the interaction of all the other factors, that is the host, the microbes, and the diet. Now, in the only problem with traditional Keys-Jordan diagram was that it was accused of being too simple, or it was accused of having oversimplified the etiopathogenesis of caries. So, to make the model more specific, a lot of other circles were also added to the model, like primary modifying factors. You can see that on your right. Secondary modifying factors like socioeconomic status, education, lifestyle, environment, all of these. So this on your right is the modified Keys-Jordan diagram. Now, the only problem or the only drawback of this particular model of caries is that they wrongly convey the message that all factors have to be present at the same time with the same intensity to produce the disease. Because a lot of times we also encounter patients who have a sweet tooth but don't suffer from caries. And there are some who are very conscious of their sugar intake and yet have high risk for the disease. So this particular, confounding fact is not explained by these models. So it is true that multiple factors have to act all together with each other to produce the disease, but not necessarily at the same time. Like we studied earlier, cavitations in the teeth are clear-cut signs of bacterial infection. So that accumulation of bacteria in the form of a soft tenacious film is known as a plaque biofilm or a biofilm, which we'll now be studying in detail. So like you can see in this table, there are various sites which have different predominant species. Usually enamel caries is caused by Streptococcus mutans, dentin caries, Streptococcus mutans starts the caries, and Lactobacillus is responsible for progressing the caries. Root caries is most commonly caused by actinomyces. So dental plaque is a term that has historically been used to describe, like I mentioned before, the soft tenacious film that accumulates on the surface of the tooth. And dental plaque more recently has been referred to plaque biofilm or simply biofilm, which is a more complete and accurate description of the composition. So there are various salient factors of a plaque biofilm. That is, it is mostly composed of bacteria, their byproducts, extracellular matrix, and water. And the accumulation of biofilm on the teeth is a highly organized and ordered sequence of events. It happens over a period of time. Teeth normally have a biofilm community dominated by Streptococcus sanguicidor or Streptococcus mitis, with significant difference in proportions. Like you can see in the table, I've already mentioned enamel caries, dental caries, root caries, they all have different predominant species. The population size of MS on teeth varies, and mainly it is MS which is responsible for karyogenicity of the biofilm. And mature plaque biofilms, that is older biofilms, have tremendous metabolic potential and they're capable of rapid anaerobic metabolism. So more the anaerobic metabolism, more is the production of organic acid, more is the demineralization. Here is a diagrammatic illustration of the colonization during plaque formation. Like we discussed earlier, plaque biofilm is a highly organized and ordered sequence of events, the formation of a biofilm, that is. So on your left, you see a simple image which shows a plaque biofilm attached to the enamel in a smooth surface, non-cavitated lesion. And on your right, you see various stages in the colonization during plaque formation. Plaque, like we discussed before, are gelatinous and they tenaciously adhere to the tooth structure. If you use disclosing agents, they're visible to naked eyes, and thick plaque biofilms or older plaque biofilms are capable of great metabolic activity and producing a large amount of acid, resulting in greater demineralization. So like you can appreciate, it's an ordered sequence of event. On 30 at 30 minutes to 1 hours you see an acquired pellicle. 12 to 24 hours you see more accumulation of bacteria. 1 to 3 days the bacterial accumulation has increased, and of course over 3 weeks you can see large corncob appearance and a thick plaque biofilm. Before discussing the demineralization and remineralization cycle, it is necessary that we understand a very important factor, that is the critical pH. So a critical pH, although Sturdivant is the standard reference textbook and it has defined critical pH for enamel to be 5.5 and for dentin to be 6.2. But in reality, critical pH is not a definite value. The critical pH of any solution or any biofilm is just inversely proportional to the concentration of calcium and phosphate. So it is the pH at which a solution is just saturated with respect to a particular mineral, or for example the tooth enamel. That is, if we say that the pH of the plaque biofilm is above the critical pH of the mineral, then the solution is supersaturated with respect to enamel. So more minerals will tend to precipitate out. And conversely, if the pH of the biofilm is less than the critical pH, so that means the solution is unsaturated. So the enamel will tend to dissolve. This will result in demineralization. This entire concept is important and for you to understand, because this is how you will understand the demineralization and remineralization steps, because it is the low pH that drives the calcium and phosphate from the tooth to the biofilm, because the entire cycle is all about reaching an equilibrium. So when there is low pH, it drives the calcium phosphate from the tooth to the biofilm, resulting in demineralization. And when the pH in the biofilm is neutral, or when it reaches to neutral, then the concentration of calcium phosphate is supersaturated relative to tooth. So therefore, their calcium and phosphate are added back to the tooth structure, resulting in remineralization. This is the demineralization remineralization cycle. The diagram very clearly and succinctly describes the entire cycle. Firstly, the cariogenic bacteria in the biofilm metabolize the refined carbohydrates and they produce organic acids as byproducts. Now, these organic acids, when they're present in the biofilm for an extended period of time, they lower the pH of the biofilm to below a critical level. And like we discussed earlier, critical level for pH, so to say, critical level for enamel, critical pH for enamel, so to say, is 5.5 and dentin is 6.2. So the pH of the biofilm comes down to below the critical level. Then the low pH drives the calcium and phosphate from the tooth to the biofilm so that an equilibrium can be reached. So therefore, there is a net loss of minerals from the tooth, resulting in demineralization of the tooth. And then when the pH in the biofilm returns to normal, the concentration of calcium and phosphate is supersaturated relative to that in the tooth. So then these minerals, calcium and phosphate, are added back to the partially demineralized enamel. And this particular process is known as remineralization. So this process takes place several times a day over the entire lifespan of a tooth, and there are various factors modifying it. It can be oral hygiene, diet, dental anatomy, use of fluorides, salivary flow, etc. Now, repeated demineralization events, like we discussed earlier, there are pathologic factors and then there are factors that promote remineralization. So, repeated demineralization events will result from a predominantly pathological environment, which will result in localized dissolution and destruction of the enamel, finally resulting in caries or a cavity. Moving on to the clinical characteristics of dental caries, there are three distinctly different clinical sites for caries initiation, and the characteristic of a carious lesion will vary with the nature of the surface on which the lesion is present. So, three different sites are the developmental pit and fissure of the enamel, which is the most susceptible site. Second are the smooth enamel surfaces that shelter cariogenic biofilm, and third is the root surface. So each area has a distinct topography, different environmental conditions. So therefore they have a distinct biofilm population. Like we discussed earlier in a table, they had different predominant species, enamel, dentin, and root. And so the diagnosis, treatment, and prevention of all these different lesion types usually take into account the different etiological factors which are operating at each and every specific site. Now, coming on to the classification of dental caries. So, according to Sturdivant, they've classified caries according to location, direction, extent, rate, and histological depth of penetration. So, according to location, there is primary caries and secondary caries. Primary caries is the original carious lesion of the tooth, and there are three types: pit and fissure, smooth surface, root caries. Secondary caries usually occur at the junction of a restoration and the tooth, and they may progress under the restoration, also known as recurrent caries. According to direction, there are forward caries, backward caries. We'll be studying all of these in detail in the upcoming slides. According to extent, there is incipient caries, also known as the early white surface lesions, which are reversible in nature, and then there are cavitated caries, which are irreversible and require restorative treatment. According to rate, acute caries or rampant caries, and chronic caries or slow arrested caries. Lastly, according to histological depth of penetration, enamel caries is where the caries is usually confined to the enamel, and dentinal caries is where the caries is confined to the dentin or has spread to the dentin. Coming on to primary caries, first variant is the pit and fissure caries. Pit and fissure, as we discussed earlier, they're particularly susceptible surfaces and they harbor a community dominated by Streptococcus sanguine and other streptococci. In cross section, gross appearance of pit and fissure lesion is usually an inverted V. What happens is that the initial lesion first develops on the walls of the fissure and then the demineralization follows the direction of the enamel rods. So it starts spreading laterally as it approaches the DEJ. That is why it always has an inverted V shape in cross section. Remineralization of the enamel happens very often because of trace amount of fluoride in the saliva. So it makes the progression of pit and fissure lesion very difficult to detect. Sealing the pit and fissure in susceptible patients after tooth eruption is one of the most important uh, treatments that we can do to increase the resistance to caries. Second is the smooth surface caries. The proximal enamel surfaces immediately gingival to the contact area are the second most susceptible areas to caries. A rough surface usually restricts adequate biofilm removal and it favors the occurrence of caries. So lesion starts on the smooth enamel surfaces and they have a broad area of origin and a conical or pointed extension towards the DJ like you can appreciate in the diagram A, B, C, and D, how the lesion progresses, and how on cross section it has a smooth surface caries as compared to, in comparison to pit and fissure caries, has a V shape, whereas pit and fissure has an inverted V shape. So for smooth surface caries, V shape with the wide area of origin and the apex of the V directed towards the DJ. Root caries. Now, our root caries lesions have less well-defined margins and they tend to be U-shaped in cross-section. They spread almost twice as fast as enamel caries or dentinal caries, mainly because the cementum covering the root surface provides very less resistance. And also, in addition to that, the critical pH for dentin is higher than that for enamel. It is 6.2. So, demineralization starts even before the pH reaches the critical level for enamel. Very commonly, it is seen in older patients because of other factors like decreased salivary flow, poor oral hygiene because of reduced dexterity, and decreased motivation and gingival recession. Secondary recurrent caries, they usually occur at the junction of the restoration and the tooth, like you can see in the picture on your right. They are often termed as recurrent caries, and this condition clearly indicates microleakage under the restoration, very commonly seen under composite restoration because of shrinkage. Second are the backward caries. Spread of the caries along the DJ in backward caries exceeds the caries in the continuous enamel. So the caries extends into this enamel from the junction and is termed as backward caries. For forward caries, the caries in the enamel is larger or at least the same size as that in the dentin, like you can appreciate in the photos on the right. Incipient caries or white spot lesions are usually first evidence of caries. They appear opaque white when they are air dried and they seem to disappear when wet. And they can be characterized as reversible because they have the potential to be remineralized. Cavitated caries are caries surfaces where the enamel surface is broken. They usually, this lesion or this caries is advanced into the dentin. Remineralization for this is not possible and the only way to treat this is to get a restoration done. Acute or rampant caries is the caries that rapidly damages the tooth. It is seen as numerous soft light colored lesions. Since they occur so rapidly, there is less time for extrinsic pigmentation, therefore, these are lighter in color. Second are the chronic or slow or arrested caries. This disease is episodic over time and it is not seen as extensively and not like how acute caries. It is not seen in numerous tooth. It can only be found in few locations in the mouth. The lesion is discolored and it is usually hard because of pigmentation and fluoride release. You can see the encircled portion on your right. It is an example of arrested caries. And an arrested dentinal lesion is usually open, dark, hard, and this type of dentin is known as eburnated dentin. The histological depth of penetration, they can be caries can be defined as enamel caries or dentinal caries. Enamel caries is also of two types: non-cavitated enamel caries and cavitated enamel caries. So, like we studied earlier, non-cavitated enamel caries are white surface lesions. They have chalky white opaque areas. They lose their translucency because of the subsurface porosity, which is caused by demineralization. They can be remineralized and they're usually seen on the facial and lingual surfaces of the tooth. Cavitated enamel caries are the ones where there is a visible breakdown of enamel surface and only restoration is the mode of treatment. Now, coming on to the zones of enamel caries, there are four zones in the incipient lesion when it is examined in quinoline by transmitted light. First zone is the translucent zone. It is the deepest zone, represents the advancing front of enamel lesion. The name refers to its structureless appearance because when perfused with quinoline solution and examined with polarized light, it appears translucent or structureless. The pores or voids here are seen along the enamel prism boundaries, and the pore volume of this zone is 1%, that is 10 times greater than normal enamel. Second zone is the dark zone, and it is known as the dark zone because it does not transmit polarized light at all. The light blockage or the darkness is caused because of the tiny pores that are too small to absorb quinoline. The smaller air-filled pores make this zone appear opaque. The pore volume for this zone is 2 to 4%, and the size of dark zone is a clear indication of the amount of remineralization that has recently occurred. Third zone is the body of lesion, which is the largest portion of the incipient lesion, has the largest pore volume, 5 to 25%, and bacteria may or may not be present in the body of the lesion. Zone 4 is the surface zone, which is relatively unaffected by caries, has the lowest pore volume, that is less than 5%, and it serves as a barrier to the bacterial invasion. Next are the zones of dentinal caries. Zone 1 is normal dentin. This is the deepest area in normal dentin, which has tubules with odontoblastic processes that are smooth. The intertubular dentin has normal cross-banded collagen and apatite crystals. No bacteria are present in the tubules, and the stimulation of dentin by osmotic gradient or by a burr or by an instrument or by heat or air will produce a short sharp pain because of stimulation of A delta fibers. Now zone 2 and zone 3 are very important: affected dentin and infected dentin. So zone 2 is the affected dentin. It is also known as the inner carious dentin, and it is a zone of demineralization. In this zone, you can see clear damage to the odontoblastic process. Affected dentin is always softer than normal dentin because there is a loss of mineral. The collagen cross-linking usually remains intact in the affected dentin, and this same intact collagen can serve as a template for remineralization. Affected dentin is capable of self-repair provided the pulp is not non-vital, and the affected dentin in itself can be subclassified as subtransparent, transparent, and turbid dentin. Zone 3 is the infected dentin, which is the outermost carious layer, the layer that the clinician would encounter first when opening a lesion. It is marked by widening and distortion of dentinal tubules, and they are entirely filled with bacteria. Very little mineral is present, collagen is irreversibly denatured, and this dentin zone, unlike affected dentin, cannot self-repair. The two major differences between this affected and infected dentin is affected dentin has reversible reversibly denatured collagen, infected has irreversibly denatured collagen. Affected dentin still has some potential for remineralization, whereas infected dentin cannot be remineralized, and removal of infected dentin is essential to successful restorative procedure in spreading the infection. Now, traditionally, for detection of infected dentin, two factors were observed, that is the degree of discoloration, that is extrinsic staining, and hardness using an explorer. But these are not entirely reliable, so Fusayama came up with the dentin staining method, which helps in better differentiation between remineralizable and non-remineralizable dentin. So the Caries detection solution that is used is 1% acid red 52 or acid rhodamin B in propylene glycol, and this particular solution stains the irreversibly denatured collagen, that is, it stains the infected dentin, but it does not stain the affected dentin. So it provides a more conservative tooth preparation. Now the pulp dentin complex is a very active complex, and it does show reaction to invading bacteria. There are different dentinal reactions to caries. The reaction to a long-term low-level offending stimulus is usually the formation of sclerotic dentin. The reaction to a moderate intensity attack is reparative dentin, whereas the reaction to a very severe, rapidly advancing caries with high acid levels resulting in higher demineralization is usually pulp necrosis, which is the death of the pulp.